So I'm going to talk a little bit more about platelet-rich plasma. You see on the left here, it's a picture of me injecting a knee joint. This is right after we've done a TPLO surgery. You can see that small incision there on the left. The device on the right, this is blood that's been collected from a dog. It's spun down. The top layer there that's kind of yellowish looking is our platelet poor plasma. And then you have a little buffy coat there in the middle. It's got kind of a white color to it. That's where most of our platelet-rich plasma is going to come from. Then the bottom part is all the red cells and white cells that we were able to concentrate to the bottom of the tube. So in the old definition, PRP was defined as being at least a concentration of platelets, 106 per microliter. Now we're looking at some of these newer devices that are actually generating anywhere from 2 to 8 times the concentration of PRP. So if a dog has 5,000 platelets, for example, some of these newer systems out there are making 40,000 out there. And there's no studies that are confirming that concentration is really important in animals, other than we want to get it higher than what's originally in the animal. Studies out there are saying 4x, 6x, 8x. Some people believe that you can get too high of concentration. Some people don't really seem to think that's a big deal. You can take platelet-rich plasma and concentrate it or activate it with calcium chloride, and there's a certain way of doing that with a formula. And although this is slow to create a gel, what we use this for is bone grafting or non-union fractures. So we can inject that into the spot there where you have an open hole in a bone or space in a bone. We can accelerate growth or healing of that bone quite a bit. What we're looking at in PRP is this thing called an alpha granule, and it releases proteins which promote platelet aggregation when they're activated. Platelet-rich plasma is a great growth medium for stem cells, so anytime we submit tissue to a lab that we know we're going to culture it, we'll send a PRP sample along with it. Growth factors in PRP do a really good job of potentiating effects of mesenchymal stem cells, and they actually have been found recently to turn the stem cells on. As you said earlier, tendon injuries, things like Achilles tendon ruptures. There's 4 different types of ruptures there, and there's some in the class 2 that are actually treatable with PRP as well as surgery. Muscle injuries, we see a lot of these in hunting dogs and German shepherds. Joint laxity may be a component of cruciate tear in dogs who've had it for a while. And we do know that probably stem cells as well as PRP are pretty good at treating cartilage and meniscal injuries that occur secondary to cruciate tear in dogs. Some people just use PRP as their choice for treatment of osteoarthritis in canine joints, and I think that's mostly stems from people out there that don't want to give their dog drugs or don't have time to give their dog drugs, or there's a group of dogs out there that don't do well on some of the medications we give for arthritis. So we try to get those patient categories into the regenerative medicine group. So you can see in the picture here on the left, the platelets, that little tiny purple cell in the middle, doesn't have a nucleus. There's, as we said earlier, the alpha granules are probably the more important ones. Platelets are very famous for clotting, and they also have some growth and healing factors in them that can be pretty important, particularly in the younger stages of life. So we look at some of these different types of white blood cells. They're in platelet-rich plasma. Monocytes have an increase in cellular metabolism. They decrease the release of anti-angiogenic cytokines. We probably want an increased concentration of monocytes, but we don't have a whole lot of studies yet to support this in veterinary medicine. Lymphocytes, we don't really know how much we should have in there. The significance of them is still quite unknown, what they can or can't do in terms of PRP treatments. Platelets do activate for full blood mononuclear cells to help stimulate collagen production, which is pretty important, as you all know, when we talk about healing from different types of injuries. We want to have a decrease in the neutrophil count in there because neutrophils have some of these unwanted inflammatory mediators like interleukin-1 beta, tissue necrosis factor, interleukin-6, and interleukin-8. As the concentration of neutrophils in PRP goes up, there is some correlation there with increased MMP9, which degrades collagen and other extracellular matrix molecules, which again are part of healing from soft tissue and orthopedic injuries. So, here's another list of some of the things that we have treated with PRP. Again, a lot of our work has been done in orthopedic injuries because that's primarily what our practice focuses on. I've seen some good studies on stomatitis in cats. I've seen some good studies treating dry eye in dogs. We've done some pretty good work with bone healing. I've seen nephropathy, renal disease in cats is probably going to be the future for stem cells, and there's some good work done out there. As you can imagine, the difficulty comes when the animal goes into kidney failure. They typically don't have fat or bone marrow to give for us to culture and procure stem cells from them. So this is one of those areas of focus where if I were in general practice, I would try to encourage people that are bringing their dogs and cats in to be spayed or neutered to collect fat then and get their stem cells when they're young. There are at least 86 ailments and illnesses that we found in the literature here with a recent search that have been treated in PRP. In humans, probably the biggest thing they treat there are things like plantar fasciitis, tennis elbow, carpal tunnel, other types of muscle injuries that athletes get. So how much can you charge for this? It's always important as veterinarians because we're trying to run a business and trying to make a profit off of what you do, but be reasonable about it. I've seen PRP injections anywhere from $400 to $800. Stem cell injections can run quite a bit higher. And again, I think this depends on how you procure them. If you're doing a point of care system, making them yourselves versus sending them out from culture, but anywhere from $1,000 to $3,500. And a lot of it ends up being collection and lab fees. Protein concentration injections are a little bit higher than PRP because it takes a little more product and a little more time to lyse those platelets. So you just have the protein concentration left behind. To give these injections into the joints of animals, we have to sedate them, and in some cases, we actually anesthetize them for doing injections in the cerebral spinal canal, for example. And these patients end up staying in the hospital for a few hours for a couple of reasons. One, to recover from the sedation and anesthesia, and secondly, to monitor any potential effects from either poking a needle in the joint or the potential for any kind of reaction to what you've done. We have never seen allergic reactions from stem cell injections, but it's always recommended to keep the patient in the hospital for 2 to 3 hours after you do the injection. So people ask, what's the difference between PRP and stem cells? So, we said PRP is a concentrated platelet or enriched platelet in plasma, has these different growth factors, has a half-life that's fairly short. We like to think of PRP as being a fertilizer for tissue repair, whereas when we talk about stem cell therapy, these are cells that may engraft and support tissues for life. So this becomes the new seed. So these two are complementary, and when we're treating patients with stem cells, we quite often will add PRP to it, and we don't even charge for it for doing stem cell therapy. And I like to do that because I think that PRP makes the perfect vehicle for stem cell therapy, and because one works with the other, the two are going to be very synergistic in their effect. And we've seen some very, very positive responses in some of our therapies, particularly when we're doing post-op after knee surgery. So there are some good studies out there combining the two. Some of these studies are starting to become controlled and blinded. We're still having issues with controls on there, and I think it's difficult to get control populations in most of the things we do, at least in orthopedics. Injections in the hip in this one study were done when they were doing stem cells and PRP. You see the word end or A there, that just means activated. In this particular study, they had 8 lame dogs who were followed for 6 months, and all patients made some substantial improvement in their pain control and lameness scores. So, the big question is there an appropriate dose? I don't think we have a really good answer to that. And the reason for that is because we don't know what it takes to treat a particular condition. We haven't taken 10 dogs with the same degree of arthritis, given them all the same amount of PRP or all the same dose of stem cells, and then being able to monitor those effects. Younger patients are going to have better responses to stem cells and PRP compared to older patients. I think we do know that if we're thinking of stem cells as being a drug, more is not always going to be better, and we really need to figure out what the minimum maximum doses are. Right now, we just give a lot of stem cells. You're going to see biological differences in stem cells or PRP from one patient to the next, and a lot of it has to do with the manufacturing and delivery process. We're not all producing them the same. We don't have gold standards figured out yet or defined by the industry. Defining these dosages is going to be the biggest obstacle to us making the standardization of the production of these products for regenerative medicine. So, I always like to ask this question too: is the method you're using appropriate? And we say this because people go to Google and they go on the internet and they search for, how can I make PRP at home and not have to, pay money to this company to give me this PRP kit. And sometimes they'll use citric acid tubes to try and make their own. But, all these questions are pretty serious questions to think about. Can you produce a consistent product? Do you have red blood cells in there? If you think about it, you don't want to put red blood cells in the joint. It's called hemarthrosis. And if you ever had any bleeding in your knee joint after an injury, that's quite painful. Verification of PRP counts is difficult because you can't analyze some of these PRP samples with a lot of in-house cell count systems that people are using. A lot of these systems that you might be creating on your own from these little things on the internet leave you open to the chance of infection because they're not closed systems. And you're certainly not going to know what your neutrophil, monocyte, or lymphocyte count is in that sample, and they may be too high or too low. So when you're trying to come up with a protocol, you want to tailor to every patient's needs. Some of the earlier theories out there talked about giving stem cell PRP injections every 2 weeks for a series of 3 injections. I think now we know this is probably not as necessary as we once thought it was. Some of the first studies that are coming out there in the literature are only giving 1 injection, monitoring these dogs for 6 months. And if you read the studies, you see that even at 6 months, these dogs are still doing very well, and they probably could have been monitored out for a year or a year and a half. Some of the protocol injections that have been extrapolated from humans have talked about 30, 60, and 90 days injections, follow-up and injection 6 months and annually. We find a lot of owners only bring their pets in as needed for injections. And, if you give 1 injection of PRP, the dog does great. They don't ever come back until the dog starts to limp again. I think because of these reasons, every vet has a different protocol. If you're going to do stem cells, I highly encourage you to mix PRP and stem cells together because you're going to get a better response to that. Right now, what we're doing is we'll give a stem cell injection or we'll do a PRP injection after cranial cruciate surgery. We spend most of our day doing TPLOs and TTA surgery. And I think probably 3 out of 4 now we're giving PRP injections with the client's blessing and certainly with them paying for it. And we're seeing some very nice responses. We're not seeing problems with infection and delayed recoveries that we did before we started doing that. So what do you expect after giving an injection of this? You're going to have some discomfort 2 to 7 days afterwards, and that's going to come from having a needle stuck in your joint. And if you've ever had an intra-articular injection, you know that it's quite painful to have that done, just because you're increasing the volume that's already in there, and there's really no place for it to go. So the pressure increase can become uncomfortable for a little while. One of the other things that might cause some of this uncomfortable feeling is that if you're using stem cells, a small portion of the stem cells are probably dying in the next day or two in there, and that may create an inflammatory reaction as well. You can manage this pain with gabapentin, or if it's really bad, and we've never seen it so bad that we've had to prescribe narcotics, a lot of times we'll just use a little bit of gabapentin and tell the owner to rest the patient for a few days. We don't do steroids with PRP, and you don't want to give the newer NSAID called Galliprant for up to 2 weeks afterwards, and 1 week before giving the stem cell injection. We tell clients to ice the area for 2 to 3 times a day, probably for 5 to 10 minute periods. Hypothermic therapy can decrease platelet activation, so that's something to keep in mind. We try to get our clients to think about rehab. It's not really necessary after we do stuff like this, depending on how well the dog's done. Your commitment to rehab should be based on what you're seeing clinically. So if the dog isn't doing well, if the dog has some muscle weakness associated with the injury, it's probably a good idea to think about rehab. But we're not saying commit to rehab here because you gave PRP or a stem cell injection. We tell people to restrict their pet's activity for 3 or 4 weeks after the injection, and that's because of the nice pain control effect we get from it. These animals start to feel really well, and they go out and hurt themselves again. If a patient has some redness around its injection site after an injection of something like PRP or stem cells is given, this isn't normal, so I always tell clients, please bring the patient back in if you have any concerns at all. So, special considerations of regenerative medicine. If you know an animal has cancer, you really don't want to be offering regenerative medicine, not in the current clinical form that we're capable of doing. It's not compatible with infections, so if you have an active infection in a joint, PRP is not a good choice. Obviously, if an animal has a coagulopathy where they would have a decreased clotting time or a decreased number of platelets in their blood, we probably don't want to be recommending regenerative therapy. Still can use NSAIDs. Don't use an injection with steroids for at least a week or so. And don't use this to replace emergent intervention procedures. So really what we mean by that is dog has a cruciate tear or patella luxation or something crazy like that. Regenerative medicine is not going to fix those kind of things. If there's a mechanical problem that requires a surgical intervention, then that should be taken on as well as doing the regenerative medicine. So we recommend regenerative therapy to our patients when they're on NSAIDs and they're not working. And this can happen in a number of patients if they're taking NSAIDs for too long. They're having idiopathic or idiosyncratic reactions to it. Typically that involves the liver, the kidneys, or the GI tract. We see up here in our area groups of clients that can't, or won't give the prescriptions every day, whether it's an inconvenience to them or they feel like, I don't take drugs, so I don't want my dog to take drugs. And it makes it difficult to control their pain. They say in the literature that 30% of dogs who have had knee surgery are still in pain afterwards because we don't have the perfect surgery out there to fix that. We do have clients that seek alternative therapies because they're doing it for themselves for some reason, so they might reach out to us for some recommendations of regenerative therapy. When patients can't go to surgery, regenerative medicine is a good choice. And, as someone that's focused primarily in surgery in our career up here, we try to have the right patient to go to surgery because we want them to be successful. So this may be the really old dog, or maybe a dog with a comorbid disease, an endocrinopathy, or something that would impair their ability to heal. They may have cancer. They may have an ailment on multiple legs. When surgery is not likely to work, we might think about regenerative therapy. So this would be the osteoarthritic score 5 patient who has significant degenerative joint disease on an X-ray. This is probably more conducive to diagnosing end-stage osteoarthritis. Fortunately, our patients don't look at their x-rays and think bad thoughts that they can't go out and exercise, so they tend to stay quite active even though their x-rays tell you otherwise. So the ideal case, you want to have a clearly defined disease or lameness. If they're non-surgical candidate, then they're probably a good case for doing PRP or stem cells. As I said earlier, if there's a surgery you can do and the client's willing to do it, I would highly recommend you get that out of the way. You don't want to do this in dogs that have a whole lot of articular osteophytes because you may not be able to even get the needle in there. When you're doing these injections, you want to limit it to 1 or 2 joints. If you inject, 6, 7, or 8 joints at once and there's a problem, then it's going to be difficult to figure out what that problem was, and it'll be more difficult to be able to resolve that. You don't want to treat patients that have major systemic diseases because regenerative medicine may somehow have a negative effect or it may not work at all. We like to say no major spinal disease because if a patient's neurologically weak, then they may not be able to get up, but sometimes we're treating that neurological disease, such as irreversible disc disease or degenerative myelopathy of German Shepherds. Really important to make sure your owner has rational expectations. Our numbers that we quote to clients are that in most conditions, 85% of pets are going to show a positive response. And that means 15% aren't going to show a response. And those are the ones that we need to make sure the clients understand that. Do not add antibiotics or anything else to regenerative medicine that could not only cause problems with the stem cells, you may kill the stem cells inadvertently by injecting something in there, but more importantly, this is against federal law to do that. So why do we get pain control from regenerative therapies? If we look at these drugs, a lot of these drugs that you see here with the big X over it, they're just hitting one specific cell receptor or 2 specific cell receptors. But when we start looking at things like regenerative medicine, we are hitting multiple receptors at multiple levels in the pain pathway. So we get a much more broader and safer control since we're using the body's own system to do that compared to using the drugs you see on the list there. Things like tramadol, there's quite a few reports out there now that substantiate tramadol is probably not a good drug for use in dogs, but we still give it to them. Things like gabapentin don't really have any drug synergism with other drugs. We're sort of questioning whether or not that has any ability to control pain. We know that in general, NSAIDs given over long periods of time tend to cause problems with kidneys, the GI tract. And if you have a fracture, you might see a non-union, or if you have a TPLO, you may see it not heal as well on dogs who stay on NSAIDs for more than a couple of weeks. Okay, let's take a look at some case studies. So if we're doing an elbow injection, obviously we're going to sedate these patients. I want to use a very, very aseptic technique. I typically use a 22 gauge needle or larger. If your needles get too small, they might cause some lysis of the cells as they go through the needle. If dogs have quite a bit of arthritis in the joint, it might be difficult to get into there. So we're injecting the elbow, and we just kind of run a thumb down the medial side as we get to that condyle down there at the end on the medial side, and it starts to go back down that little slope there. Typically, you can walk the needle right off the edge of that bone and have it drop into the joint. It's important to realize and certainly keep in mind that joints don't have very large volumes, so you might not get more than 0.2 to 0.75 cc's of fluid into a joint. You can inject that fluid around the joint as well, and I think you're still going to see a pretty good response to that. Hip injections are, I have to say, quite a bit more difficult because the joint is located deep. If the dog has a lot of atrophy in their hip, you might find it quite easy to get a needle into the hip joint. These are definitely done under sedation, use an aseptic technique. We like to duck the hip a little bit, and I use spinal needles for this because they're 3 to 4 inches long, depending on what size you're going to use. we'll just drop that needle right off of the femoral head and have it fall down into the joint space. If you draw back on the plunger a little bit, you should get some fluid out of there before you make that injection. So here's just a quick picture of us doing a injection into the hip. This is after dog had worked on his hip. We put his hip back in the joint because he had a luxation, so we did a toggle pin on that. Stifle injections are probably the most common one that we do in practice because we probably 60 or 70% of the day we're doing knee surgeries like TPLO and TTA. If you're doing these as follow-up, you definitely want to do them under sedation and use an aseptic technique. When we're doing them after the surgery, obviously the patient's still asleep, and we consider our injection site to be fairly clean, although we'll do a quick surgical scrub right after we've completed the surgery before we put the PRP injection in there. You can align this needle either medial or lateral to the patellar tendon, and if you just make a little triangle between the tibial crest, the patella, and back in the knee joint, and put the needle in the middle, you should fall right into the joint space. If dog has a significant amount of osteoarthritis present in their joint, you may find it quite difficult to get that needle to pass into the joint. And here's a dog. This is looks like Nicole's hand. She's getting ready to do an injection, so she's just palpating the lateral aspect. You have the knee joint. You can see the patella tendon right next to her thumb, and that's where she'll most likely place the injection. And let's see, here's another one. We don't do a whole lot of shoulder injections in dogs. You know, the occurrence of shoulder disease seems to be pretty small up here. I think just living in the big city, we don't have people that own very large dogs where you might see more problems with the shoulder, such as osteochondrosis. These are also done under sedation. You want to use an aseptic technique. I usually will lay the dog loudly with the affected leg up, put a towel right underneath the shoulder joint, and then use that as a leverage to open up the shoulder a little bit. If you drop your needle off of the acromion and go straight down, you're probably going to miss the shoulder joint. So I will go a little bit distal to the acromion and then aim the needle proximal, and you should fall right into that joint fairly easy. And it's usually pretty easy to aspirate quite a bit of joint fluid out of there. If it's the first time we're injecting this joint, I may take some of that joint fluid and send it off to the lab for cytology just to rule out other causes of immune arthropathies. All right, so now we're going to start taking a look at some patients. Here's a dog named Buddy. It was a massive mix. He had surgery on his left leg, and we were going to do his other leg a little bit later. I like to stage knee surgeries apart just because it makes recovery a little bit easier on the dog. Buddy had adipose harvested from falciform ligament for stem cell therapy.
Slow down, buddy. Good boy.
Absolutely have to be in the knee joint. Here's another video of Buddy.
Okay. All right, let's not go up the steps, buddy. Hold on, hold on. I want to help you. Okay. Good boy. Okay. All right, let's not.
Okay, just a little bit more about Buddy. Samson is, in this video, he was about a year and a half old. He was King Corso. He had his ears done, his tail done. I don't do that stuff, but it always makes me wonder how mad or angry these dogs are, because they are raised as fighting dogs, so it's hard to tell whether or not Samson was a happy dog. We recently did a 10-year follow-up on Samson, and we're very happy to see that he still doesn't have any major signs of degenerative joint disease in his knees. He's got a TTA in his left knee, and he's got a TPLO in his right knee. Samson had really only a couple of stem cell injections, because at the time we weren't able to do harvesting and send it to a lab for any type of culture. Samson's had a few PRP shots over the years, and we've been real happy with how well he's doing, and his owner is certainly quite happy as well. So let's take a look at Samson here. And good boy. Just let me in. Let me in. Sam, come on. In the best of situations. Olive was a 2-year-old terrier mix, and we had also harvested fat and sent it in for culture at a lab, and they keep it stored for us. Olive has some pretty significant issues with the elbows. Well, here is a video we got of Olive. This is 2 weeks post injection, and we said PRP at that time because we didn't have stem cells back from the lab yet.
Okay, Olive, come. Olive, psst, come. Come on, I want to see how you're walking. Come. Olive, come.
Here's Okay. So Olive came back in for about a month later, had a stem cell injection done along with some PRP, and we have not seen Olive for a couple of years now. And the client keeps in contact with us, sends us videos every now and then to let us know how well she's doing. Hopefully she'll continue to improve and keep moving around, and have our patients live a lot longer than they might have with bad arthritis. Lincoln was this cute little Bichon Frise, actually belonged to a veterinarian that worked at this clinic. She saw us do a lot of TTA surgeries and decided that TTA was probably a good surgery for her dog. And we have a little video here of her. She's about a month and a half now after surgery.
Come on.
Here's another little dog. This is Buddy. It's a little smaller dog, only weighed about 30 pounds, a little terrier mix. So we actually did point-of-care stem cells for her because the owner didn't want to keep coming back for stem cell injections. They drove a very long ways just to get stem cell therapy and knee surgery done on their cute little dog. So let's take a look at their video.
It's all right. It's all right. You're doing good. You're doing good.
Shooter was a patient that we did a TPLO on. This dog was 12 years old and complete cruciate tear. We did PRP injections into both stifles at the time of surgery. And this is a video from our client. She happens to be a veterinary technician, but I think she's a stay-at-home mom now. Tara is 2 weeks post TTA and had PRP injections into the knees. Was done. We've had to do surgery on the other leg, and we've done a couple of more injections of PRP for her, and she's doing quite well. And this is Sophie. Sophie had TTA performed the night before, and for some reason we had to come back the next day to get a PRP. I think this is because the client changed her mind and decided that she wanted to have PRP injections done.
Hi. Looks really good. Awesome. Cool, thank you. I'm just gonna grab the tubes and we'll be right in.
Okay, so in summary, I think PRP is a great addition to any practice. It's easy to make PRP and obtain it. It's something that you can have your technicians do. I think it's a good profit center. I think if you look at your appropriate groups of patients are the ones that you are sending NSAIDs out to a lot. These patients are having to get repetitive blood tests done. You're worried about their kidneys or stomach. You're worried about the long-term effects of NSAIDs. These are the ones you can switch over to regenerative medicine. As I said, my technician does all this stuff, so there isn't something that the veterinarian really has to get into. I want to make sure you check your state laws to see if your technicians are allowed to give injections into the joints. Very simple procedure. We have lots of videos that you can find on YouTube and on the internet that'll show you how to do that. And there's usually some lab going on somewhere in the U.S. during the year that can get you some hands-on experience with that. I don't get too concerned about whether or not I hit the joint. I try to, but if I miss or if I find I can only get a quarter or half a cc in there, then I'll pull a needle back and just kind of inject around the joint. They've been pretty successful at convincing most of our knee surgeries and other types of joint surgeries and certainly fractures to sign up their patients for PRP injections or stem cell injections. If you had asked me a couple of years ago which one I preferred, I may have said stem cells, but I think certainly in the last couple of years we've come to the conclusion that in the right patient, which is usually typical middle-aged dog getting knee surgery, I don't think they have to spend all the money on stem cells. I think the PRP is going to probably give them equal response that they would see to either of those. And maybe we should be reserving stem cell therapy for more advanced stages of arthritis or other conditions in dogs.